as well. There were any questions that you may have throughout the presentation, please hold on to them. Either write them down on a piece of paper. We'll have an answer period at the end, or write them down in the chat box. If you can see the chat box function, Alexa will record all of them, and then we'll address everyone's questions. And maybe somebody had a question that you didn't think of, and then you thought of it. So we'll all those as we go. Okay, so bear with me. Brand new mommy brain. I have to remember how to share my screen, and we'll do that really quickly. Bring up the presentation. Let's just admit you. There we go. Can everybody see my screen? Wonderful. We love that. So as Maureen said, oops, I hit forward too quickly. As Maureen said, this is a monthly webinar series that we'll be holding over the year. This is the second series that we've done. We're so excited to be back. Alexa and I will introduce ourselves in just a little bit. So it is the Living with COPD and Asthma Ask the Experts webinar series. Our topic for January of 2024 is understanding your COPD, and we tagged in a bit of asthma with that as well because they can be similar. Okay, so as I reminded everybody, questions in the chat box, or hold on to them till the end and we will record it. Okay, so we'll do a quick introduction. I'll let Alexa go first.
Hello, everyone. So my name is Alexa McMillan, and I am a respiratory therapist at Royal Inland Hospital here in Kamloops, BC. I have been an RT for almost 10 years, and I have worked in almost every position that an RT can work in. Currently, I am the assistant practice lead here in Kamloops, and some of you may know me from doing this, as this is our second year doing our webinar series. So if you do, some of the things that have changed with me is that I am now back from work, or back to work after having my second baby girl. But one thing that hasn't changed is my passion for sharing this education with you all.
Wonderful. Thanks, Lex. And as you've heard my name a few times, my name is Lindsay Wetterstrand, and Alexa and I did this series last year. We graduated the program from Thompson Rivers University together. And just like Alexa, I had my hand in pretty much every area that you can in respiratory therapy. I am a casual respiratory therapist at Royal Inland Hospital. However, I just completed my first full teaching year at Thompson Rivers University, teaching in the respiratory therapy program. So I kind of like to teach to people, and I like to hear myself speak, I think. So a little bit of that. Over the past year, some big things have changed for me, just like Alexa. My husband and I moved into our brand new home. I finished my master's of education, and I had twin baby girls. So if I stumble or I yawn, it's not because y'all are boring me. It's because these baby girls are all night long. Okay. So we'll just jump into the schedule. So it's going to be running from January till the end of December. However, we do have some breaks. The first talk we're going to do is understanding your COPD and asthma. So there is a lot to talk about. We're trying to bring it down so it's as easy as possible. Okay. Next month's talk is on February the 21st. We were going to have them on Fridays. We've had to switch to Wednesdays, so the new date is the 21st. We'll be talking about bronchial hygiene again. March 27th, we've got activity in COPD, so we've got a familiar face who's a physiotherapist. Jill will come in and chat with you about that. We're really excited about our April talk. It's wildfire smoke and extreme heat talk, which I think is a topic a lot of us, especially in BC, are aware of and concerned about. May, we'll talk about COPD medications and updates. There's some new medications that are out there that we should talk about. We have a summer break, June, July, and August. Okay. Nobody wants to do any learning. Everybody wants to enjoy the sun, and hopefully it's not smoky. So we'll take a break and we will resume in September. We'll talk about the new RSV vaccine for patients with COPD. We'll talk about COPD action plans in October, and we'll wrap up in November talking about COPD, stress and anxiety that can come with it. And then there's that winter break in December. Okay. And then hopefully we'll start again the following year. One thing I really want everybody to think about is, as we work through these topics, what are some topics that you might be interested that we can add in for next year's series? Because we are always looking to update our topics. Okay. So today what we'll cover is a few different areas. Alexa will begin the talk defining, providing causes, the impact of tobacco smoke, the types of COPD, and signs and symptoms of COPD. So she'll give a nice background. Then I will talk about the impact on respiratory structures, the main structures that we see in a lot of our patients day to day. Then we'll talk about kind of really briefly the effect on our breathing, summarize really quickly, and then that's when we'll take our questions, okay? So I'm going to hand it over to Alexa and let her start gabbing away.
So let's start it off and ask the big question. What is COPD? So I want you to think about these two questions that I'm going to ask next and really think about them and just hold those questions. If you have any questions, just put it in the chat box and I hope that we'll be able to answer them for you. So question 1, what do you know about COPD? And question 2, what do you want to know? So hopefully we can answer these questions. And if not, at the end of this presentation, we're going to have a lot of time for some question Q&A so we can answer those questions for you. So what does COPD stand for? So the C stands for chronic, meaning that it won't go away, but it can be managed. The O stands for obstructive, meaning the airways are narrow and floppy and can cause the airways to collapse when we breathe out. So if we're unable to breathe out, all that air, some remains in the lungs, and this decreases the room for the next breath in. All of this resulting in shortness of breath. So it causes an obstructive process. P is for pulmonary, meaning that it affects both of the lungs. And D is for disease. Like all diseases, there's a range in severity. So for COPD, that range can be from mild to very severe. Next page. So what causes COPD? The main cause of COPD is having some form of smoking history, where 80 to 90% of COPD disease is caused due to some form of tobacco smoke or smoking history. Quitting smoking is the single most effective way to slow down the progression of COPD. Now, smoking isn't the only thing that causes COPD. 10 to 20% of people diagnosed with COPD have other factors that have led to their COPD. So these factors can be genetic factors, such as alpha-1 antitrypsin deficiency, environmental exposure, so being exposed to a lot of pollution or secondhand smoke for a long period of time, childhood viral infections. Now, this wouldn't be from one viral infection, but several severe ones. Occupational exposure to heavy fumes, chemicals, fine particle dust that's breathed in over and over, and or chronic asthma that is left untreated or not managed properly. And we'll dive a little deeper in how that relates to COPD. So with tobacco smoke being one of the most common causes of COPD, let's dive a little deeper into its impacts on the airways. When someone inhales smoke, such as cigarettes, vape, you get the picture, this causes the tiny hairs that line our airway, also known as cilia, to become paralyzed, so they stop moving. Cilia's main job is to sweep the mucus up and out of our airways. So if we are causing these little hairs to stop moving by paralyzing them, we aren't getting that mucus up and out of the lungs. This results in the mucus staying in our lungs and becoming a breeding ground for bacteria. And if there's repetitive exposure to the smoke, to these tiny hairs, it further causes damage and results in these cilia pretty much stop working. So if you can imagine this, the cilia stops working, less mucus is getting out. And with less mucus getting out, this increases our chance of getting lung infection. And it releases these destructive enzymes that cause protein loss inside the lungs, which that results in the airways not being as elastic. So all of this can result in the lung being scarred, floppy, and that's what's trapping that air inside the lung. So smoking causes that destruction at the very, very end of our airways called the alveoli. And this is where the irreversible damage occurs. And we're going to dive deeper into this in a little bit. So when we talk about COPD, it's a broad term that encompasses different types of COPD. So that being either chronic bronchitis, emphysema, bronchiectasis, and asthma. So let's look deeper into each one of these. So first one, chronic bronchitis. So this is inflammation and scarring of the lining of the bronchial tubes. So those tiny tubes within the airways. When we have inflammation in the airways, this decreases the room for air to move in and out. So some symptoms of chronic bronchitis are coughing, increased mucus production, frequent throat clearings, there's lots of mucus in there, and shortness of breath. So I wanted to put a question back out to you guys. Have you ever had bronchitis in the past? Just regular bronchitis? What were your symptoms? Think about how did that, your breathing change? Now think about that all the time. So having it chronically occurring all the time. That's what someone with chronic bronchitis feels like. So let's take a look at the structural changes. And these, when looking at this picture, we can see on the left-hand side, this is what a normal bronchi looks like. Now, if you look on the right, we can see what a bronchi looks like with someone with chronic bronchitis. You can see that there's swelling of the airway lining, and there's increased mucus production. As you can see, looking inside, that yellow stuff is mucus. Now look at the diameter, so the inside of the airways. The one on the left, that normal bronchi, we have a nice big open, we call it a lumen, nice big open airway to get air in and out. And if you look on the right, it's a lot smaller of a diameter because that's swelling, that mucus that's in there. So air has a harder time getting in and out of that lung, resulting in shortness of breath feeling, and just feeling that, you just can't get your breath, chest tightness. But what you can't see is there's also scarring happening and destruction of the elasticity of the airways. So the airways become floppy and they close sooner than what you would see on the normal bronchi. Now let's look at emphysema. This begins with the destruction of the air sacs. So those tiny little air sacs at the end of our airways. So these are known as our alveoli. So our lungs start with our trachea, and they branch and they branch and they branch till they get to the very, very ends. And these are very delicate little membranes called alveoli. When damage occurs here, this damage is usually irreversible, and it results in holes being formed of these tiny, tiny tissues. The destruction will impair gas exchange to occur. So air can't go across into the blood or oxygen, and we can't get that CO2 to come out what we need to exhale. So we have damage that occurs at these tiny airways. In a healthy lung, we see oxygen come into the lungs and go into our blood, and CO2 leave our blood and us exhale it out. But when there's this damage, we lose that elasticity and we get those holes, we don't see this gas exchange occur. So someone with emphysema, some of their symptoms they may have is coughing, extreme shortness of breath, and very limited in exercise. And another big key thing that we see is usually weight loss. So let's take a little bit look at those structural changes. When we look at this picture, the top part of it, we can see a normal alveoli. This is looking at a snapshot of a healthy lung. You can see all these tiny little sacs. And all these tiny little sacs have a huge surface area, and this allows for gas exchange to occur at the very end of our lungs. When we look at the bottom picture, we see an alveoli with these big holes in it. You don't see those nice sacs, tiny sacs formed. So there's less surface area and therefore less gas exchange that can occur. So we see not much oxygen getting into the blood and CO2 staying in the blood. So that's not what we want to see. So our next group that we have of COPD is bronchiectasis. Causes of bronchiectasis can be from repeated pneumonia, tuberculosis, dysfunctional cilia, so meaning those cilia that we were talking about that help get the mucus up, they just don't work. Or there is a syndrome called Cadogan syndrome. So this is a combination of chronic sinusitis and dysfunctional cilia, so just not getting that mucus out. Airways and bronchiectasis become overstretched, and they form these pockets that collect the mucus. So as you can see in this picture here, this airway is overstretched and there's lots of mucus that's just forming in there. With bronchiectasis, we tend to see copious mucus production. And this is due to, again, the lungs being abnormally widened, leading to that buildup of mucus. And so, like mentioned before, when you have this buildup of mucus, it's a breeding ground for bacteria, and then there can be infection that forms. So patients with bronchiectasis tend to cough anywhere from 1 to 1.5 cups of mucus per day. And this is why we highly encourage, physiotherapy to be involved with them, and different techniques like postural drainage and drainage techniques to help get that mucus up and out so that we don't have that infection occurring. And we're going to talk a little bit more about this whole subject in our next month's lecture in February. So stay tuned. Lastly, it's our last a term that we mentioned, that category of COPD, and that is asthma. Wait, what? Asthma? This one always confuses people. Yes, asthma falls under the term COPD, as it is an obstructive disorder. However, it has some key differences. Just like COPD, it is an airway disease that makes it hard to get air in and out of the lungs, but it's from different causes. In asthma, the airways tend to be overreactive or sensitive to irritants. Those irritants are smoke, dust, pollen, allergens, scents, emotions, exercise. Different things can trigger the effects of asthma to become obstructive. So the reactivity, all of this being exposed to some form of allergen or something like that, will cause inflammation to form inside of the airway. And that inflammation and swelling inside the airways can alter the air from coming in and out. It also affects the smooth muscle that lines the airways. So as you can see in the picture, our airways are lined with those muscles. It causes those muscles to tighten. So if you look at the first slide diagram of a normal airway, you see these nice smooth muscles. You have the inside lining of the airway nice and open. And then as you progressively look down, we see someone that has increased inflammation. And then on the last picture, that tightening of the muscles. So look at the difference in diameter. It's going to be a lot harder to get that air in and out because there's that narrow airway. So if you can visualize someone that has that swelling and squeezing of the airways, you can only imagine that their symptoms are going to be wheezing, because you're not going to be able to get that air in and out. So we tend to see those people wheezing on inhalation and expiration, coughing, increased mucus production, that chest tightness, because you can't feel like you're getting that air in and out, and of course, shortness of breath. So asthma left untreated. So if we don't treat this can result to scarring that could also happen inside the airway, and loss of elasticity, which then it results in that irreversible damage. Next slide. So let's compare. We talked a couple of examples of COPD, and then I brought in asthma, because I know that sometimes this kind of confuses people why asthma is found under COPD umbrella, but it is also differentiated a little bit differently. So let's compare and contrast them. For asthma, the onset is typically early on in life. So usually we see it in childhood. There are some cases where asthma is found in later on in life, in adulthood, but that's usually because of risk factors such as GERD. With COPD, on the other hand, we usually see its onset usually midlife, because damage doesn't occur overnight, yet it's a period of time of repetitive injury where we see it. So it's usually seen later on in life. For asthma, symptoms usually vary day to day, depending on what they're exposed to, what their triggers. And we tend to see these symptoms worsen more at night or early in the morning. Whereas COPD, symptoms are usually progressive. They start slow and they progressively get worse and worse over time, especially if they're not being managed properly. Asthma, it's more associated with things like allergies, rhinitis, eczema, where we don't typically see that in COPD. And COPD, on the other hand, is more associated with a smoking history. However, there can be other factors, like mentioned before, genetic factors and exposed to repetitive smoke, etc. Big thing though, with asthma, it's largely reversible. So we can give medication to target that inflammation in the airways, and we can give medication to help relax those smooth muscles. And we should see some sort of reversibility and opening of the airway. So there isn't that obstruction. However, if we leave it to go for a long period of time, then that's where we're going to see that irreversible damage and more of that COPD looking case. In COPD, this is irreversible. The damage that is done, we can't reverse it, but we can prevent it from getting worse. So overall, we can look at COPD and its signs and symptoms. I'll skip you to the next slide, Lindsay. Thanks. So the main symptoms of COPD are a cough, whether that be with mucus or a dry cough. You may have mucus production that either can be all the time, or you may not have mucus production. You may have shortness of breath, and that can range from exerting yourself up to just sitting at rest feeling short of breath. It's progressive, so COPD develops slowly and it gets worse over time, but that's why we have medications to help prevent it from getting worse, and so that you're able to do your daily activities. And then it's permanent. So unlike asthma, like I mentioned before, it can't be reversed, but we can prevent it from getting worse, and we can manage those symptoms. And I'll hand it over to you, Lindsay.
Yeah. So that was quite a bit of information, and I know there's a lot to think about and how it affects you. What I want to talk about is the impact on respiratory structures. Now, there is a lot of information that we could provide and go into, like I said, but we're going to focus more so on the most common ones that we've seen. So the respiratory muscles, the diaphragm, the accessory muscles, and the airway smooth muscle. We'll talk about the lining of the airway, and Alexa talked about cilia, or those fine hairs. And then we'll talk about the impact on the alveoli. Now, she's already chatted a bit about this, but we're just going to focus a little more on it. So the main muscle of inspiration for us, the main muscle that does all the work of breathing, is our diaphragm. That's 80% of the work of breathing. And I want you to think about some numbers. We take about 20,000 breaths a day. So every year it's about 7.5 million breaths. And for somebody who's about 80 years old, that means we've taken 600 million breaths. I had to count the zeros on this. It blew my mind. 600 million breaths. And there's one main muscle, the diaphragm, that does 80% of this work. So it's always working all the time. So it has to be working at its peak efficiency. Where it's located is right below the lungs. You can see those nice pink lungs and kind of the orange thing that's scooping down. It separates our chest from our abdomen, and it's actually made up of two halves. We call them hemidiaphragms. They're nice rounded halves that meet up to work together. So in a normal functioning diaphragm, a patient that does not have any respiratory issues, what the diaphragm is going to do during inhalation is it's going to contract, or it's going to tighten up and get smaller. When it does that, it actually is pulled down into the abdomen. So I want everybody to put your hands on your tummy and take a big breath in. And what does your tummy do with your chest? Tummy should lift with your chest as well. That's the normal function, because your diaphragm is pushed down and scooped and pushed your tummy contents out of the way. Okay, so that's normal. It's going to lift the ribs with the accessory muscles doing some work, and it's going to help us suck air in. We don't push air in, we suck a breath in. When we exhale, there's no work involved. All the diaphragm is going to do is relax, go back to its nice shape, lift or return upwards into its normal position, and the ribs are going to relax down, and it's going to push that air out. So that's why we say that exhalation is passive. When we have a patient that's experiencing COPD, any of the COPDs, we're going to notice some changes with them. Now, one of the biggest ones is we're going to notice that normally, like I said, the diaphragm should be nice and rounded and in its preferred spot. But because with COPD, it's obstructive, we do not exhale all of that air out. It's going to stay trapped in the lungs. And what that air is going to do is actually push down on the diaphragm, and it's going to flatten it. So you can see that top image where you see the lungs and the diaphragm. The one to the left is nice and normal. We fully exhale, the diaphragm is round and it's come up. The image on the right of that top, you can see the diaphragm is flattened down and the lungs are a little bit bigger. It's because that extra air that we can't exhale out has stayed trapped in there. So that now diaphragm that should be round is a little flattened and it's not in its optimal spot. I want you to think about this. I teach my students this all the time. Have you ever picked up your bags of groceries? You only want to make one trip, so you load up your arms and you get into the house. Now, if you start with your arm fully extended, are you as strong as if you had your arm at a 45-degree angle or a 90-degree angle? Muscles have a preferred position to work their best, and with COPD and pushing it and flattening it down, it's not in its preferred position. Okay. The other thing that happens is because the diaphragm's in a different spot and we're trapping more air, our ribs are lifted up a little more. And so you may hear a term called barrel chested. And you can see the image on the bottom shows the patient on the left. They're nice and exhaled, the ribs have come back and their chest isn't puffed up. On the right-hand side, air trapping makes them have a bit puffed up more chest. So we commonly see that change as well. Because the diaphragm doesn't work as well as it should, and the chest is puffed up so it's not moving as effectively, we move less air. So if you go to your physician's office or your respirologist or your nurse practitioner or respiratory therapist, whomever takes a listen to your breathing, they may not hear as much air in and out because there's less room to whoosh air in and whoosh air out. I like this image a lot because it shows x-rays. Okay. On the left-hand x-ray, you can see that I've got an arrow pointing down and I have flat shape and lower. So the diaphragm is a little flatter because there's air pushing it down. And this isn't just holding your breath once, it's years of air being trapped in there to push it down. So chronic, that's that COPD. And it's flat and it's lower. On the right-hand side, you can see it's nice and round and it's a little higher up because that's its preferred spot to work. When we talk about accessory muscles, we've got a few of them. Now, if the diaphragm does 80% of the work of breathing, the accessory muscles are going to do 20%. And that's all they really should do. They're just accessories. They're like little rings or jewelry, okay? They're not the main show. We've got a few, if you look at the image, we've got the sternocleidomastoid, so that nice big muscle that runs down each side of your neck, if you ever felt it. You know, you go like this and you can see it. We've got our pectoral muscles, we've got subclavian muscles, we've got intercostal muscles, internal and external intercostal muscles that help pull the ribs up. So they should do some work of the breathing. They're not that efficient, they use up some oxygen, but when the diaphragm doesn't work as effectively, these guys need to step up and do more work. They're not meant to work as good as the diaphragm, so they can tucker out. So if you ever feel really short of breath and then you feel like, oh, I got to slow down, that's where breathing techniques, and we'll talk about those coming up, can help out as well. Okay. The more these little muscles get used, if the diaphragm doesn't work as effectively, just like any muscle, the more you use it, the bigger it becomes. So then you may notice that these are a little more prominent, or your muscles, when you're pulling up, you can see them lifting your rib cage because that's how they're trying to help open up the lungs and get a breath in. Okay. Like Alexa said, just a quick rundown of all of our airways. We've got our trachea, that's our big windpipe. That's the biggest puppy of them all, like the trunk of a tree. And then we've got our main stem bronchi, which branch to the left and the right lungs. And then those bronchi, they branch and branch and branch 23 times. They get smaller and smaller and smaller until they're size of a thread. At the end of these terminal bronchi are our lovely little alveoli. These airways, especially the small ones, have muscle that wrap around them, and they're supposed to be nice and elastic so they can stay open when we exhale. They also have this lovely inner lining, but let's talk about the muscle first. So as Alexa mentioned, with asthma or with COPD, if you have something that irritates it, it can tighten up and squeeze that airway, decreasing the inner lumen, the size inside of it. But also what can happen with chronic damage day after day, year after year, is that this muscle can be damaged. That nice elastic fibers in our airways can get damaged as well. And so the airways can flop shut if we exhale, and that's what happens, or they can tighten up. That airway lining, I love putting animated pictures in. It's easy, right? So Alexa talked about cilia, those fine little hairs, okay? The airway lining has these fine little cilia, these hair-like structures, and what they do is they sweep mucus up and out of the lungs. And trapped in that mucus is any kind of bacteria, dust, any particles you may have breathed in during the day. Okay. In that airway lining, we also have mucus cells, which we need mucus to keep our lungs nice and moist and happy to work the way that they should. But when we smoke, tobacco smoke, or anything that can irritate them, initially it will paralyze them so they don't work. They stop that sweeping motion. And so all of that nice, juicy, thick stuff that's warm and ooey gooey stays down in the lungs, and it's dark and warm, and it creates a nice breeding ground for bacteria, which we don't want to have happen. After chronic exposure to tobacco smoke, these cilia actually can be destroyed. So then they're not even paralyzed, they're just not there. And so you may note that you're not clearing as much mucus. One really common thing that we hear is when somebody stops smoking, within, I think it's the first 24 hours, they start clearing up a lot of mucus because those cilia that are still there are working. They're happy. They're like, hey, let's clean the house. There we go. At the end of these little air sacs, finally, are these little alveoli, and we love alveoli. There are so many, I think there's 300 million. So you got one or two to spare, but we don't want to lose all of them. They're very small, they're extremely delicate, and they look like bunches of grapes. So you can see on the left, that's normal air sacs. They're nice and healthy. And each one of those little grapes provides a surface area for oxygen to go into our lungs and carbon dioxide, that waste gas, to come out of our lungs. That's what we want to have happen. But damage to these little walls can have them break down. And instead of little, nice little sacs, you've got kind of floppy bulli or bulbous things that don't really participate, and they trap air. And that's why you can see your oxygen levels go down or your lipid levels go up if they're tested. So really, how does that affect our breathing? Well, if you think about oxygen coming in when we inhale, we need the muscles to work. We need the airways to be open. We need the alveoli all to work so oxygen can come in. And when we exhale, carbon dioxide come out of the blood through those open airways and out. So it's really important that we maintain that or optimize it as much as we can. Healthy lungs, they can balance the two of them, no problem. But when we have damaged or diseased lungs, they may be ineffective in balancing it. Okay, now Alexa has a question for you.
Little pop question for you. How much air do you think we breathe in a day?
Just
Oh,
ask.
my watch just asked. Okay, so how much air do you think we breathe in a day? So you can either jump on, unmute yourself, or drop it on in the chat box. But we're just curious to hear.
And if you attended last year, you might be able to cheat. Does anybody remember?
Someone shout out an answer what they think.
In liters, let's say in liters. How many liters do we breathe in and out in a day?
20,000.
Oh, I like it. Who said that?
Wayne.
Michael did.
Oh, cheater. Alexa, what's the answer?
So the answer is we breathe out or breathe in 11,000 liters in a day. So 20,000 was lots, but yes, 11,000 liters. So we're breathing in and out lots in a day. So putting all of this together, it's important to see how much, affecting that bit of gas exchange that happens can really affect our breathing.
Mm-hmm.
So we've talked a lot about how the air gets in and out of the lungs, and we talked a little bit about gas exchange. We keep saying this gas exchange. So let's just dive a little bit deeper into that. So as blood flows from our heart towards the lungs, it surrounds the lungs at the alveoli. So those, like I mentioned before, those tiny little sacs at the end of the airways. And then the blood vessels wrap around these alveoli, and they're with these teeny tiny blood vessels called capillaries. So they're very thin. Oxygen, as we breathe in, will come into the lungs, and it goes all the way down, like Lindsay described, to the alveoli, and then it will diffuse, meaning that it moves across the membrane into our blood. So from the alveoli into the blood. And at the same time, our body is trying to get rid of the waste products, mostly carbon dioxide, and that moves from our blood into our lungs so that we can breathe it out. And that is what we call gas exchange. So as you look at the picture, we can see air coming in, O2, crossing that membrane into and getting onto those nice blood cells and turning red. And then we want to get rid of that waste product, that CO2. It's leaving our blood, crossing into our lungs so that we can exhale it out. So if you put together everything we talked about today, and you're unable to exhale because your airways are floppy and they're closing early, or there's that inflammation, or, all these processes that we've talked about, and we can't get that air out. So that CO2 starts building up in our blood, and that oxygen is unable to cross over into our airways. That's why we're seeing these symptoms of shortness of breath and, chest tightness. All these things are kind of building up onto that. So super important that we kind of get that we understand that concept of how air and oxygen moves in and out of our lungs.
Mhm.
So in summary, we've talked a lot today, but if you were to take away a few points, just know that the lungs, they're a complex organ and they have many components. Excluding asthma, so don't think about asthma at this part, but damage that occurs is irreversible. But symptoms and further damage can be managed, and managing that progression of the disease. And we're going to talk a lot about this going forward in the next few PowerPoint slides over the months. Recognizing that COPD has different types. So we talked about chronic bronchitis, emphysema, bronchiectasis, and therefore they're going to have different treatments. So depending on what you have, you're going to have different symptoms, you have different treatments. So what works for you may not work best for someone else. So now we are finished talking and giving all this information. We're going to turn the table over to you guys, and we're going to answer some of these burning questions that you may have. And I see that we have a few in our chat box, so we'll start there. Actually, no, let's start with Wayne. You have your hand up. Why don't you unmute yourself and we'll take your question.
Yes, I'd like to know at what point is the exchange made in the lungs, the oxygen and carbon dioxide? Is it like on the inhale? Is it at the point where you decide to exhale, or during the exhale?
Wayne, it's all the time.
Mhm.
It's all the time. Yeah, the exchange is happening as blood is cycling past all these alveoli. It is happening all the time. And it happens really fast. It's like 0.75 seconds. So when you take a nice fresh breath of air in, oxygen is filling up, and it's a slow kind of process, and it fills up all the airways and then all the alveoli, and it's crossing across, and CO2 is coming out. And then when you exhale, it's mostly CO2. But that exchange can happen all the time. It doesn't stop when you go to exhale.
The only time it stops is if there's damage at those alveoli. So if there's scarring, if there's blood, something that's damaged also with the blood vessels, they're not wrapped around the alveoli. So if there's any damage, that's when it doesn't occur. But
Yeah, that's I have the COPD, emphysema, as well as asthma.
You
So
do.
I
So
have
you've got a combo.
a real difficulty exhaling at the best of times. So
Now, do you do any breathing techniques? I don't want to jump into it because we will be having our physiotherapist talk about breathing techniques, but those can really help. And
Oh, yeah.
one thing that we really stress with patients with COPD or asthma is listen to your body. Don't try and push yourself. If you need to stop and take a breath and exhale, stop and take a breath and exhale. Let
Yeah.
yourself do that. If people think they can push through it, it actually puts you in a worse spot. So, but we'll definitely talk about it. So keep those questions in mind as we work through the series, and we'll definitely, hopefully, be able to answer those. And if not, then we'll find the answers.
Okay, thank you much.
Oh, you're very welcome. Alexa, you have questions?
yes, so let's start tackling the ones in the chat box. First question, that's for me. Is floppiness in the airways the same as tracheobronchial malacia? Relatable, but I think when you're thinking about the floppiness in the airways, it's more due to the destruction that happens in the airways, and it's more of the change in pressure. So when we breathe in, like Lindsay was mentioning before, and then we breathe out, there's a pressure change within our airways. So when we exhale, it's the elasticity of our lungs. We open up our airways because there's a pressure, and then as we exhale, and they shouldn't fully close. We always have them open. We have this, what's called an intrinsic PEEP. Our lungs stay open. But what happens with people with COPD, you lose that elasticity. So as you exhale, your lungs close. Now you can't get all that air out. And then as the disease progresses more and more, sometimes it'll start to happen more sooner. and that's where that trapping is going to occur.
And with the tracheobronchial malacia, what it means is that there's issues in the larger airways, and so it's not necessarily a breathing technique that can help those stay open. I have heard, I don't know how frequent it is, you'd have to speak to your specialist, but there could be surgical options for the larger airways like that, because the trachea does have these C rings of cartilage that are supposed to keep them open, and so sometimes they can help with that issue versus those tiny thread-like, this airways, they're a size of a thread. There's no surgery that you can do to keep them open, right?
And that's why we always are teaching that pursed lip breathing, because pursed lip breathing, when you breathe in through your nose and then you purse those lips and breathe out, that's creating a pressure back into your lungs that helps stint those airways open so they aren't closing early. So we're going to talk a lot about that next, I believe, bronchial hygiene. We'll talk quite a bit about that in our next February lecture. But always good to practice, especially if you're feeling short of breath. It's just to take a break, do your pursed lip breathing, and it takes a bit to kind of get it going and get familiar with it. But as you get more and more familiar with it, you're able to do it more on the fly. When you're exerting yourself, it's just really going to help stint those airways open. It's a great technique just to help that gas exchange to occur. All right, second question. What can I do to get the mucus out of my lungs?
Well, stop jumping the gun.
That's what our whole next presentation is on next month, but we will give a little bit of spoilers. There's different types of cough techniques. Alyssa, who's your guest speaker next, she's a physio. She does a great presentation on this, and she does some great demonstrations. So there's different types of huff coughs that help just bring everything in. There's different positions. So we say postural drainage, different ways we can kind of tap on our lungs to help bring the mucus. But there's also tools that we can get too. So like PEEP devices. One of the big ones that you may be familiarized with is called the Aerobica. And it's a device that you breathe on, and it can help vibrate in your lungs and help shake up that mucus so that you can cough it out. So again, she's going to talk about those. Those are good for people that have copious amount of mucus to get out. If you're just someone that just has like an odd cough with mucus, they aren't really the most, they're an expensive device and they're not as effective for some. But if you have copious secretions and you're constantly coughing up mucus, the Aerobica or some sort of oscillating device is a really great tool to use to get that mucus out so that you're not getting those infections. But that's what our whole talk is next month.
And one of the easiest things that I think a lot of people forget about is, and I know this is gross, but if you've ever coughed out a goober or a big chunk of mucus, you'll notice that it's kind of thick. It can be sticky. You want to thin that out. So make sure that you're hydrating. Okay. That's one of the best things. Yeah, with water. I've got water in my coffee mug. Because you can't add water to mucus, it won't absorb it. But when mucus is generated in our lungs, the more water we have in us, yeah, for sure, it'll help thin it out. And maybe it's a little bit easier for you to manage. But hold on to those questions as well. Like Alexa said, next month, Alyssa is going to be doing a whole spiel about it. And this is her wheelhouse. I mean, we love mucus.
I don't have a question, but
Yes.
you mentioned Aerobica. I use Aerobica in the morning, every morning, more or less.
Perfect.
And it does help.
That's great.
Okay.
Do you bring up lots of mucus after?
Sorry?
Did you find that it helps bring up mucus for you after?
Yes.
Awesome. Those devices are also good because they're, I mentioned PEEP, so positive end expiratory pressure. So what those devices are doing is it's also when you're breathing on it, it's creating a resistance that you're breathing. So it creates a back pressure into our airways to help keep the airways open. So like we mentioned with COPD, one of the big symptoms is that the airways are closing too soon. So sometimes what those devices do is when you're breathing against a resistance, it helps keep those airways open so that we can have that gas exchange and we can help that shortness of breath. So that's another really great tool to use.
I think the problem with it is we think that if we do the exercise with the Aerobica, right away we will get the mucus out. But sometimes it takes half an hour to an hour, sometimes 2 hours. Once you cough it out, it comes out. But it does help. It does help. It will get the mucus out. Just be patient. practice it, and it will work.
Tell
Yeah.
everybody you know.
Good,
That's
good tips.
exactly what we love to hear, is people actually saying how it was for them.
Yeah, and I know Alyssa's going to repeat this next week, but if this is something that you're like, oh, this sounds like something that would be really beneficial to me, Costco is the cheapest place to buy one of them. They unfortunately aren't covered under medical that I'm aware of. I don't think that's changed. You do not need a Costco card to use the pharmacy at Costco. So out of all the places that we know that they're sold, Costco seems to always be the cheapest place to get them.
Mm-hmm. Fiona, you just had phenomenal questions. Your third question is, how do you know exactly what type of COPD you have? You have to do a breathing test, and generally you have to do a full pulmonary function test so that the respirologist or the physician that's looking after you can get those exact numbers and figure out exactly what's going on. That in combination with your symptoms and an x-ray potentially can help determine what you have. And you may have a few of them. You may only have one type. You may have asthma combined with emphysema, but you definitely, if you haven't had a breathing test, you need a spirometry at minimum to get the most information you can to help.
I've had all those tests done,
Yeah.
and not once, and I've had them more than once.
Yeah.
Because I also have lung cancer as well.
Okay. So
and
yeah.
Never once have I been told what kind of COPD I have. And that's why I asked you. I can't pronounce that word, tracheo, whatever.
Malaysia. Oh yeah, it's a big one. It's a few syllables.
But that shows up on my CT scans. And
Yeah.
it's so I understand what you were saying about the size of the airways,
Yeah.
but that shows up in quite a few of my scans. And when I reviewed it, it says about the floppiness, etc., and etc.
Yeah.
And that was one of the reasons I asked the difference. But
Right.
I don't know if I've got emphysema, if I've got asthma, if I've got bronchitis. So I guess it would just mean me asking
Yes.
my respirologist.
100%. You say
Yeah.
I have COPD. What exact type do I have? You might have a couple. I mean, the tracheal bronchomalacia is one beast, and then unfortunately the lung cancer is another one. But then if you know exactly what's going on, then it can give you more power to
Exactly.
understand it. Yeah, and manage your symptoms, which I think we all just want to know and know how to help ourselves, right?
Because you were explaining like some treatments are different. I mean, I'm on the Nero Ellipta, and I don't think it helps me at all. I don't think any of those help me. I mean, they possibly could, but I feel no different in my breathing after I use it, or even for hours after I use it.
Okay.
So I'm wondering if I'm not getting treated the proper way.
Yeah,
If
I'm curious to know, like, it's hard for us to be able to give those recommendations without seeing your full picture and seeing everything that's going on. Anora is an interesting choice to be on for COPD, but being followed by a respirologist, I trust that they see the back end stuff. But we're going to talk all about drugs in the next couple months. But yeah, there's a lot of different things. Try not to get so focused on, I don't know what type of COPD I have. A lot of them are like, if you don't know if you have chronic bronchitis or emphysema, when it comes down to it, that's not going to change. Like, oh, we found out they have chronic bronchitis. Oh, you actually have emphysema. Okay, we're going to change everything. Everything for treatment wise comes down to severity and your symptoms. So COPD is treated a certain way and asthma is treated a certain way. Asthma's got a lot of inflammation, so we want to make sure we're using those steroids daily to make sure that we keep that inflammation down so we don't have that damage. And we're going to get right into this in the medication lecture. And then COPD, like we said, it's an umbrella term that has a bunch of, chronic bronchitis, emphysema, and bronchiectasis in it. Those each ones have just a little bit different reasons what form of COPD is, but we're treating the symptom. Your shortness of breath. So we're going to target and give you bronchodilators. And it's just fine tuning those ones till we feel that your symptoms have resolved or you feel better. And sometimes it's fine tuning and just giving it time, giving those medications time. What people do is after a week, they're like, it's not doing anything. You got to give those medications sometimes 3 weeks to really see if it's working for you or not. So if you're
How
finding
about
you've been on,
3 years?
okay,
Well,
so
and
if you've been on it, then that'd
yeah.
be definitely a conversation to say, like, I don't find my shortness of breath, my coughing isn't going away. There's so many medications out there that
Okay.
that's
Yeah.
definitely a question I would take back to your respirologist.
And
Okay.
one simple fix that, and I mean, 3 years, I'm hoping that somebody has seen you, but if you find that your medications you don't think are working, technique is a big thing with patients. And if you're not taking it, because these are medications that take a lot of coordination and a lot of inspiratory strength. And if you don't think that you're strong enough or you're using it right, ask for somebody to help you go through it. Okay. Definitely. We have to jump ahead. We only have 8
Okay,
minutes.
thank you.
But
Yeah.
thank you. You had
Thank
great
you.
questions. Yeah. I was
Okay,
told.
the next one is, I was told that the racing heart that I was feeling in my jaw is caused not by getting CO2 out of my lungs. Is that true? I've never heard that, but I'm curious to know, do you take Ventolin?
And this is to Kay, if she's still here, if you want to unmute.
Yeah, I'm
your-
here.
There you are.
Yep,
Perfect.
right next to you.
Yeah.
Yeah, the doctor just changed my prescription to another puffer.
Okay.
But I can't remember the name of it because I just started it.
That's okay. Were you on a blue puffer before?
I had Spiriva and Ventolin,
Okay.
Oh,
and now
So-
it's another one that you turn and it puffs.
Yep.
oh yeah.
A Respimat.
Yeah.
So right away, like anytime someone says to me, like, I feel like racing hard or jittery, that is one of the biggest side effects of Ventolin, and usually the biggest side effects of not taking it properly or correctly. So when Ventolin gets in our bloodstream, so if we inhale and we're not using a spacer, or we're inhaling too deep, like too fast, a lot of that medication is getting into the blood, and that is one of the main side effects of Ventolin. So
But
that
this is happening when I'm walking fast, shoveling snow,
Yeah. So
out,
it might.
out in the cold especially.
Yeah, it might be, I mean, there's so many causes, but if we don't have enough oxygen in the blood and too much carbon dioxide or CO2, it can stress the body out. And so the heart could start beating faster, thinking, oh, I need to pump more blood through the lungs because I need to pick up more oxygen because I'm not able to exhale fully in the transfer, and, the whole picture. That can be one of them. So if your heart starts to race, stop, slow
Oh, yeah.
down, catch your breath. If you have your breathing techniques in through the nose and blow it out through the mouth until that racing goes away. Now, if you have racing heart and then you've got like chest pain, jaw pain, okay, that's a whole different thing. Call 911. Okay.
Yeah, that's what I wondered, if I'm having a heart attack or if it's
Yeah,
the breathing.
and women,
Um,
we present differently, right? We don't do the same, but we're not cardiologists, so I'm not going to touch that with a 10-foot pole. However, definitely if you note that racing, stop, see if the breathing techniques can help. And if that stops the racing of the heart, remember,
It
you can
does.
listen to your body. Good. So then
Yeah.
that's most likely what it is probably
But it was
just,
the respiratory therapist that was doing the testing in the chamber that I was in.
yep.
And I was saying, it just feels like my chin is just like
Oh,
that. And
okay.
he said it was because I'm not expelling the CO2 out of my
CO2.
lungs.
Yeah. Yeah. So just pace yourself to what your body says.
Okay.
Okay. Yeah. Lovely. We're going to jump into Joy's question about stem cell treatments. Unfortunately, I do not know of any stem cell treatments for COPD.
There's
would
none that's
so-
been approved, and that's that we know that, like, there's no treatments that are out actively right now that you could do.
Yeah.
Whether that be in research, maybe, but nothing that's. Lindsay and I are pretty good at staying up to date on that. I haven't really heard of any of that.
And I haven't seen any new papers come out. I mean, it would be interesting. I mean, it would be phenomenal. Let's just say it there, but we don't
Yeah.
know of anything just yet.
Not currently right now.
Yeah.
Next question comes from David. I am told I have interstitial lung disease. Please, what is that? This is a great question. We get this a lot. Interstitial lung disease is almost opposite of obstruction. So right now we're talking about COPD. We're talking about an obstruction. Air is getting trapped in the lungs, whereas interstitial lung disease is more of a restriction, meaning there's scar tissue forming in the lungs. There's a couple different ways, and that would be a whole presentation on itself on interstitial lung disease. But the best way, the best analogy I can think of to explain it is picture an elastic band on the outside of your lungs, on the outside of your rib cage, and you're trying to breathe in. And if you had an elastic band, it's going to be hard to breathe out, and it's going to snap back in. So you're having a hard time opening your airways, and your air is having a hard time coming in, and it has a really easy time closing because that elastic band snapping it shut. That's what scar tissue does, is it makes it very stiff. Whereas what we've just been talking about for this last hour is obstruction. We can take a nice big breath in, but we have a really hard time when we exhale, the airways close and the breath gets trapped in there. So it's obstruction, the air is getting stuck in there.
Perfect.
Is there, oh, we just jumped.
Sorry,
I hope that answers that question. I have COPD and severe asthma, and I'm in need of a lung transplant. Why is there not a lot of info on lung transplants? Good question. That would be more probably for the BC, well, depending on what province you live in. Each province has their own transplant team, and it would be more that information would be on, like, for instance, if you live in BC, the BC lung transplant would be the best spot, or Alberta. Each province has their own transplant team, so that's where all that information is going to be, because they're the ones that are in the know of upcoming potential possibilities of a transplant for lung patients.
Perfect. I think that's it. I answered Wayne's really quickly. Normal heart rate range is 60 to 100 beats per minute. So anything above that is considered a fast heart rate. However, yet again, there's different heart rhythms and things that you can be experiencing. People that have atrial fibrillation normally have higher heart rates, but that's a whole nother cup of tea. And then with Ted asking, is there treatment for bullae? There is not treatment for bullae. It's irreversible. But what our goal is as respiratory therapists and your respirologists and your healthcare providers is to give you the tools to prevent any further damage and progression and manage your symptoms so that you can have the best lung function that we can help you with. I hope that answers it. That is the end of our time, everyone. I want to say thank you so much for attending. It was our first series, our first session of the series. I hope it was a good one. We would love to see you all back February 21st. Our next speaker is
Alyssa Baven.
Okay.
She is a physiotherapist here in Kamloops. She's I worked with her on the pulmonary rehab program. She is phenomenal in this next presentation, and she's going to give lots of information, tips, techniques on how to get that mucus up and out, and just talk about shortness of breath. We're going to talk about pursed-lip breathing. It's going to be great for anyone with COPD. That's going to be a really great talk.
I think so too. And remember, please think about topics as the series goes, that you would like us to talk about that may not be in this year's series. Send it our way or to Maureen, and we can hopefully integrate it into next year's. Anyway, everyone have a lovely.
Thank you, Ren. Have a great weekend.
Thanks, everyone. We'll see you
Thank
later.
you.
Thank you.